Our presentation is titled Recovery-Oriented System of Care in a Public Behavioral Health System. So I want to take just the first bit of time with you all and talk about, oh, here we go. Talk about, so I just hit the enter key, is that to move this along? No, that didn't do it. There we go. There we go. Okay, a little bit of background about the Regional Behavioral Health Authorities. I think it's helpful to give some context about how we all came to be and how we kind of get to that recovery-oriented system of services that we delivered. So I just wanted to give some background. It really started back in the 1970s, 1974 to be specific, and our state legislature felt that behavioral health services were best planned and coordinated and delivered in a regional system. So it reflects kind of the localness of what's going on in communities, the needs, and so the response then can be done much more close to the community to address those needs. So 6 regions were established. It also put into place the governance structure. So we're dealing with public funds, state funds from the legislature, federal block grant funds, and the counties have to participate through some matching funds to get access to the state funds. Our governance structure looks the same across all the regions. It's a county commissioner, a county supervisor that represents each county that's in the region. A couple years later then, more public policy was passed, and so there were dollars then appropriated for substance use as well as for mental health. Then probably the biggest event after that was in 2004, which was the Nebraska Behavioral Health Services Act, behavioral health reform it's often referred to, and that was really kind of downsizing the state regional centers. Those of you that maybe have been working in the system for a while may recall that, but it was felt that folks were better served closer to their families, their friends, their support systems in the community. So the regions all worked to develop plans to bring up more services so folks could move out of that regional center system back into the community, as well as we could help prevent admissions into the regional center. So my editorial comment is there was great work done there. It was never enough money coming out of that regional center system to bring up enough services to really support and serve everyone that we were trying to serve in lieu of going to the regional center. So there's the map of the state of Nebraska. There's the 6 regions. So Patrick talked about Region 5. That's down there in the blue section. Region 6 that I represent is over here in the eastern part. We've got 5 counties. We're the smallest in geographic size, but we've got the largest percentage of the population compared to. You can see some of the regions very large, lots of counties, maybe not a huge population, but obviously unique to those areas. Not as many resources, probably when you think about services and providers that may be in those communities. I just want to highlight some of what drives the work that the regional behavioral health authorities do. We have statutory responsibilities. You can see them listed there. So that's in the law that says this is what we have to do. So we're developing, coordinating, planning, a lot of planning that goes on about what kinds of services should be delivered in our region. And it really, so there's statute that guides that. We have regulations that guide what we do and what we don't do. And then there's contract. We have a contract with the Division of Behavioral Health that also gives us some requirements that we have to fulfill. So lots of structure around that. So as I already mentioned, the dollars that the regional behavioral health authorities get, it's an appropriation from the legislature. It goes to the Division of Behavioral Health, and then a portion of that goes out in contracts with the regions. We then add in those county matching funds and use that then to enter into contracts with community-based providers to deliver the services to individuals who are considered eligible in our system. And I think it's an important distinction. These are non-Medicaid funds. So Medicaid has got dollars that they spend on behavioral health services in their system, and we've got managed care organizations that manage that piece of it. So the regions really are a separate pot of behavioral health dollars that go out into services for treatment, rehab, recovery, prevention, and it's for individuals that primarily don't have any insurance. They may have Medicaid coverage, but maybe Medicaid doesn't pay for a particular service. We can then maybe invest funds in that area and be able to serve those folks, even if they're enrolled in Medicaid. So a lot of, I think it's important that we have the ability to respond to those local needs. So really our system is set up kind of unique compared to a number of other systems in the state. Again, some roles and responsibilities, the planning, development, local participation. We do a lot of convening with groups. We typically are the system that if something's not working well, maybe it's the hospitals that are struggling with something, law enforcement is struggling with something. It really can be anybody in our community that it feels like something's just not quite working right with access to services or something. We often get those calls. And that's our role, is to try to figure out who can we get around the table and figure out how to problem solve what's going on. So we have network management, system coordination. They really are the ones that are focused on the problem solving. We have specific kind of focus areas, the emergency system, housing services, consumer affairs, youth system, prevention, transition, and then we contract with a lot of providers. That looks a bit different too, depending upon what region you're in. A region may provide some services. In Region 6, we contract out pretty much all of our dollars. Am I still on? We're approaching this kind of as a conversation, so youth system and prevention coordination. Want me to continue? Okay, all right.
I have a few things I want to say at some point, but you keep going. I think you're doing great.
Pull me off here, I'll
I want to add to some of the things you said.
If you didn't get a word in, right? So I just wanted to highlight some of the initiatives going on in the youth system and prevention areas at the regional level. 988 awareness, I think everybody's probably heard about 988. So we're putting a lot of effort into trying to get the word out, posters, whatever we can do to help make sure that everyone is aware of that and that resources available. We're investing in the SCIP program, suicide prevention projects, so intervention, prevention kinds of activities, trainings that are available really to about anybody that will ask for that. And then we also financially support community coalitions that are focused on underage drinking, binge drinking, marijuana use, and nicotine.
Quick question on your school community intervention. How many of those are going on right now in District 4?
Region 4?
Do you have any of those statistics?
I do not know what Ingrid has. I know they have SCIP up there, but it's a good question. I'm not sure if at this moment I can answer that.
And at the same time, though, on the back of the slide are all of the regional administrators' contact information. You could reach out with an email or a phone call to Ingrid. I'm confident she'll respond.
Yeah. That's a good point. So really anything that comes across here, if you have follow-up questions, the contact information would be, that would be ideal to hear from those administrators directly. So funded services, got a list there of the various services that we invest our dollars in. I will admit that historically, we've had many more dollars invested in the adult system of services than we have with youth. Typically the youth may have other coverage, insurance, or some other system that will pick up the cost of services. But we have recently decided that we need to do more. So we have been working a lot with our school systems to identify if they have some needs for services to exist within the school buildings to help with that. Crisis response, that is available for youth and adults, and that is delivered in a variety of different ways. We have rental assistance up there. Obviously it's for 19 and over, but I think it's a good resource to know for those that may be aging out of some other system, that's available. Our professional partner program, Yeah, Amy's in the room. She could probably talk for the next hour just on our professional partner program. First episode psychosis, that is available in Region 6 and Region 3. So the central part of the state, that Kearney, Hastings area, and Region 6. And so my hope is, and if you're not familiar with that, it is, and we're using block grant dollars for this, but it's an early intervention program, and it's not just for youth. It is, I know there's an age limit, but it gets into the adult years as well. Those that are experiencing that first episode of psychosis can be eligible, and it helps connect that individual with treatment as appropriate, education for the individual, for family members, if they need vocational support, if they need educational support. It's a really well-rounded kind of a program that I would love to see it grow greater than it already is. Community Alliance, if you're familiar with Community Alliance in Region 6, is our provider for that. And Family Resource Center, that's you.
Yes, so.
You're on.
In the Region 5 system area, one of the projects that we're working on is the Family Resource Center. And I think Kim from Omaha,
Kim Havakati?
Kim Havakati just presented in the prior session, so I don't know if anyone attended that, but she talked a little bit about the Family Resource Center in kind of the Omaha area. A little different concept on how it's going to be applied, but the construct is similar. So in our 16 counties, there's going to be a partnership, or there is an interlocal agreement that we're entering into with Lancaster County in regards to the Family Resource Center. And Lancaster County is contributing approximately $5 million to build a center that will receive families, youth that are in distress, and for somewhere to go. So part of the crisis continuum that SAMHSA, the Substance Abuse Mental Health Services Administration, says a good crisis continuum will have three concepts. Someone to call, so that's when we think about the 988, somewhere, someone to respond, so across the regions we're working on, some of us are different, it looks differently across the regions, but having mobile crisis response, so that could be someone to talk the police through and help with the situation, or it could be a telehealth situation, or it's actually a licensed clinician or a peer specialist going out to the family and if they need something. And then the third component of that crisis continuum is somewhere to go. So that is how we're identifying the Family Resource Center as somewhere to go for youth and families when they're having behavioral health conditions or distress. And the services that we're looking at, we're working with the Division of Behavioral Health and releasing a request for proposal because it's the funds that we contract with the division, and we're dedicating about $1.1 or $2 million to it. Our crisis stabilization kind of center where they'll have mental health respite potentially, so you can stay up to 7 days if they can't return home or go to a relative. Just having crisis response folks sitting in the center 24/7 is the goal, to kind of receive those families as needed. We have some data from the Lincoln Police Department and from some of our outlining areas about the different times that families really are needing that. And then the third one is a emergency community support. So that would be more of a case management component, like 90 days or up to 6 months potentially, where they will help the families navigate and find the services and engage the services that they need. So, the behavioral health system is complex. We have different funding, Medicaid, we have probation has funding, Children and Family Services, we have the Division of Behavioral Health with the regions and some of our funding. So, it's difficult for families to kind of navigate and know where to go. So on the back end, we're really working hard to not burden families on what, who's the funder and how that all works out, but really folks to help them say, this is where we can go and they don't have a wait list, or this is, you really need some medication management support. Let's start there, or let's get you hooked up with a therapist. It will also have a licensed clinician that can do assessments to help gauge that. Families are going to the emergency rooms now, oftentimes in our region, and they're going to sit and wait 4 to 6 hours for that assessment. I'm seeing lots of head nods. And the goal is that they would go to the center and they would help them navigate that. There are going to be, we don't want youth not to go to the hospital. If it's an appropriate hospitalization, we want to help guide the family and kind of walk beside them to do that. But if it's not appropriate to go to the hospital and we know that they're not going to get hospitalized, let's address it and approach them in a different manner. Any questions about that or thoughts? Yes.
Do you know how many beds you're going to have available?
Right now, I think we're looking at 3 or 4. And when this will be brought up will probably be this next year. We're being real close to releasing the request for proposal. And it will be for any of the families in the community. At some point, though, we may have to have discussions, depending on the utilization, with other system partners like probation or Children and Family Services, if the utilization is coming from those systems versus kind of the families that are not engaged already. I've had some discussions about funding at some point, but 3 to 4 is kind of what we're looking at.
Are there any individual rooms or?
It's all under development right now. So when we release the request for proposal, and I talked about this interlocal agreement and a political subdivision will be developed as part of that. So it'll be Lancaster County and Region 5 systems and the city of Lincoln right now that will sit on that public political subdivision and steering kind of what the center looks like. And the provider that's awarded the services will be giving guidance to the steering committee on some of how the building looks like. For if it's dual rooms or one room, and based on licensing regulations, and obviously the best possible outcome for you and safety. Did you have a question back here?
I did, but it got answered.
Okay.
Do you have a location in mind for?
I think Lancaster County is having some discussions about that. I don't think there's a final decision. It's been kind of there's been discussions around the Bryan LGH Hospital, but nothing final, and lots of discussions going on about that. Yes?
Is there anything for the rural areas?
It's open to all 16 counties for Region 5. So, Patty talked a little bit about how as you go west in Nebraska, the population kind of starts to go down, even though they have more catchment area than their service area. So the funding, the behavioral health aid funding that the regions receive is based on population. So Region 5 is approximately 25-24%, and then if you go west, it just starts to go down. Omaha has the biggest percentage, is it 44%?
Oh, no, we don't have that much.
No, 30.
Of the population, but there's income that's a factor in that
in it
too,
as
which
well.
brings the population percentage down.
So I guess what I'm saying is it's often difficult. We wouldn't be able to have one site in every one of the 15 rural counties, but we will have the hub here that all the rural counties and all that we serve can come to that. Any of the families, and we know it may be a drive, right? If you're in Falls City, a 2-hour drive, or Hebron, an hour and a half or hour and 40 minutes. But it is open.
I was just saying, what I can say though is I know across the state, we've been seeing a lot more of these initiatives pop up with some of the other regions. Because this resource center type initiative, immediate crisis response type initiative has been very important across the state, and we are seeing similar kinds of proposals being developed in other regions.
And I think the challenge, because with 988, I think every region is looking at where is that place to go when individuals are in crisis. And I think, sometimes the shortage of providers in a region really complicates the ability to bring up those kinds of important services in their area.
Especially as you go west.
Exactly, right?
Yes.
I do have a question now. How will you correlate, because like 988 calls will come to us at Center Point and we're called out. How are they going to navigate which centers will receive the calls and how will correlate where they can go?
Well, it won't be a requirement, and I'm just talking about Region 5,
Right.
so not all the other administrators would have to respond to that question based on where they're at. But for Region 5, our catchment area, there won't be a requirement for families to go through 988 to access the center. They can go directly to the center. 988, I mean, just, I think Tom's gonna talk more about this, and I think there may be another session, but when families are having situations, that's where they can call. We want them to call there. But they will triage and go through a decision-making process to help rule in and rule out of what is the best approach for the family. Maybe my family needs crisis response to be activated, and they're gonna call in our area, in the urban area, it's Centerpoint, in the rural, it's Task, to come out to my family, if they're in agreement with that, and some may not. But they'll do the triage, but it's not gonna be a requirement to go to the center to go through 988.
But having that brick and mortar resource can be valuable because, as Patrick was mentioning with like the emergency community support, how can we immediately kind of hook an individual up with resources that they need that will help them kind of resolve the
We
crisis?
need that, exactly what you're talking about. That is exactly what we need.
So,
I'm glad to hear that. It's been in the making. We were looking back on some documents in regards to Patty talked about our coordination and planning, which is part of our responsibility as a regional behavioral health authority. We identified this Family Resource Center 20 years ago in our catchment area. And so I believe we're on the same track, right? And so forth, but it's all about the appropriation of funds.
Yeah.
And if the funds are not appropriated, then we're not able to move forward on some of these gaps and needs in our behavioral health system. And that little fragmentation that occurs, that can really bog us down. So I wanted to just backstep for just 1 minute. How are we doing on time? By the way.
10:26.
10:26, okay. So I just want to go back earlier. Part of our role as a region also is to really inform and work with the legislature and the senators from our areas in regards to what are those grass needs in our communities. Because it is very different based on what county you live in and what region you live in. So that is something that all the regional administrators, especially this last 90-day legislative session, took an active role in meeting with our senators, testifying at the Health and Human Services Committee and the Appropriations Committee, and discussing all these needs and gaps. And if funds aren't continue to be appropriated, then it will affect capacity and it will affect the response that the community can have. So I want folks to understand that our role, we really take it seriously as a regional administrator across the state. All the regional administrators do, and we are actively working with constituents on a local level with all those county commissioners and those county supervisors and listening to what they say. And they come and they supervise all the regions. One county official from each one of those regions supervises each one of the regions to have that local level of what we need. So it's just really important. I just wanted to kind of hone in on that just for a tad bit.
That's good. And I would just, I'm gonna have to say it, but
Yes.
we did lose some ground
We
with
did
funding
this
for
year.
this upcoming year. So it is disappointing, despite our efforts to educate
Inform.
state senators, we lost some ground.
There's about $10.3 million that was initially put into the budget by the division director, Division of Behavioral Health, to fund or provide a rate increase that occurred. And when the governor Governor Pillen issued his or released his budget on January 25th, he pulled that 10.3 million out. So many activities and those funds were obligated to many services across the region. So I say that because, you know, Patty and I are up here talking about, you know, we plan, we work, you know, needs and gaps, and we're here's this public safety net. And it's also very dependent on the appropriations by the legislature. Any questions on that?
How does that impact the plans of the centers? How does that?
In Region 5, at this point in time, we are still going to continue to move forward with that plan. The other piece that, you know, we worked diligently on is there's in the next biennium, so 2 years of the legislative session and the budget, the state budget, they did appropriated a provider rate increase, 5%, 3 and 2. However, they did not put funds to that. So what that does is it decreases the capacity that's available in the system. if we have to pay. So it's kind of the analogy, I was driving in this morning, I was thinking about this analogy, Thomas and Patty, and it's kind of like my grocery budget. If I say I've got $500 for groceries for the month, right? And that's what I can afford in my budget. But then groceries go up, we're gonna pay more for groceries. So I don't get more money, right? I have to buy less groceries. So that's what I mean by capacity. So we will have less therapy units or sessions available to the community. Okay. Let's talk a little bit. So Patty, you want to talk about the assessment on substance use needs that you're doing?
Yep, so that's something that's unique to Region 6, and we have, the study is not finished yet, but it is looking specifically at the substance use needs of youth in our region. So there's been focus groups and data analysis trying to look at what are we missing to meet the substance use treatment needs for youth. And I don't think it's not a surprise to anybody. We've really kind of lost ground on treatment resources for youth over the years for a variety of reasons. So, I can't necessarily predict what's in that, it will come out in the study, but I think it's probably going to identify what are those treatment and assessment resources that are needed for youth, education for parents and families on the topic as well. So I'm excited that we were able to get that done, and hopefully soon we'll have a report that we can issue and we'll post on our website.
The opioid settlement funds, you've heard, I'm sure, about the national lawsuit that kind of occurred with the Sackler family and some of the pharmacies about the opioid epidemic and overprescribing and some of the addictions that occurred. So Nebraska is going to receive millions of dollars in relationship to that lawsuit, and every state got a portion of those. And so in Nebraska, there is a statewide remediation committee that was established to kind of oversee and direct those funds. So in Nebraska, 15% of all the funds that come in will go to counties and municipalities across the state, an allocation of the funds that come in. And then of the remaining 85%, half of that will stay with the statewide remediation committee to plan and to allocate based on the statewide project. The other portion of those will be allocated to the regions based on that population and income formula. So Region 5, we just received approximately $2.5 million as of Tuesday in regards to that opioid settlement. So each region is starting to receive those funds. So with those funds, we will, the whole goal is to abate opioid addiction. That's the whole goal, and there in the lawsuit is an attachment E that outlines what are the prevention, intervention services that can occur and to help us reach that goal of abating opioid addiction. So what you'll see all the regions across the state start to do, what we do best is planning and setting up some type of structure to allocate those funds out, to bring up services or to train providers on the importance of not overprescribing. There'll be multiple different strategies across the regions. Any questions about that? Yes.
How will you be engaging communities in those meetings, and how does that allocate those funds?
It's a great question. So what many of the regions have already begun to do is to work with SAMHSA in the Opioid Response Network, and we're receiving technical assistance on how to do just that in relationship to this special pot of funds that are dedicated for that. So you'll see summits. We'll review needs assessments that have been occurring with public health districts. We'll review the data. We'll be having meetings with constituents in different local areas, and it'll look a little different, each region, based on kind of their approach. But John Hopkins Hospital has outlined an approach on how each entity that is receiving opioid funds should approach moving forward and doing the planning and the allocation and so forth. So this year will be a big, strong kind of planning, coordinating year, and hopefully the funds can start to flow very quickly, whether that be through an RFP process or a granting process. But we are responsible to report back to that committee and to the legislators to let them know what impact and what we're doing to release those funds.
So how narrow does it have to be of what the funds are used for?
Opioid abatement.
I mean, have they put hard and fast rules of what kind of
There is a very, it's called attachment E. You
Yeah.
can probably
And
Google
and
it.
it really is pretty broad.
Okay, that's what
Yeah.
I thought, it was broad.
Yeah, it is pretty broad. So that's gonna be the challenge, is how do we get that kind of narrowed down to something that we can identify priorities then for the dollars that we have. We'll have a summit. We're gonna work with a different organization to do that, probably targeting October. But, you know, we're hoping to have representatives from various systems, all 5 of our counties around the table, and then do some breakout sessions so everybody can look at their own community then and identify what their unique needs might be as we are identifying that kind of list of activities and priorities within that to spend those dollars.
For example, like in Jefferson County, which is one of our counties, there's an overprescribing beyond the national rate. So that will be something that we'll address specifically in that county we'll want to address. And it may look very different in Lancaster County as well, the approach is. Yes?
I do know that, I'm not sure who we correlate with. Hospitals will send us referrals of opiate overdoses, and we follow up and see if they want services. So there's one thing that Lancaster County does.
Thank you for
That's-
sharing that.
That's good.
It's
Because
just
I do
kind of
think
up
that
and
there's-
running. I'm not sure the logistics of all that, but
Yeah, I think there are some interventions that we are missing like
Yes.
that. So I think that's
we
good to
must
hear
do
that.
3 follow-ups.
Yeah.
Attempt 3 follow-ups
Yeah.
to 1 referral.
And I know like public health also has a grant that they're working with well-being initiatives in regards
We did that
to
too.
some of the follow-up on that. So there are some things going, and that's where we'll want to be careful with planning, that we're duplicating, but we're enhancing. Did you want to talk anything about the system of care grant?
Okay, I was just gonna mention, we've got a SAMHSA System of Care grant. We collaborate with ESU 3. And this really, Nebraska had a System of Care grant. I don't know how many were maybe involved with that. That one closed up. We then applied for something. This impacts Washington County, Cass County, Sarpy County, where we've got services that have been added into the school buildings, and we've got parent mentors that can help with parents that are experiencing some behavioral health needs with their family members. So, I think that system of care model is still alive and well in the state, and I think it still has merit and value. We've talked about the disparate systems maybe that have funding for youth or adults, whether it's probation, our system, Medicaid, Children and Family Services. I still think there's value in being able to collaborate somehow. I have to think that some of those needs for those populations look very similar regardless of the funding source. If we could maybe figure out a way to collaborate a little better so we can bring up some services and everybody's maybe got some funding that's involved in that, it really goes a long way to help sustain services that are needed in our state. So,
Last thing I want to mention on this slide is the voluntary crisis stabilization mental health respite. This is for adults, so this would be somewhere to go in Region 5 for adults. Similar to the youth, but a little bit different. So voluntary crisis stabilization is also a Medicaid service, and then we also offer that. So it'll be voluntary. So if someone's in crisis, the police can take them there if they want to voluntarily go there, which doesn't currently exist. It'll take some pressure, hopefully, off of the hospital system, and they can stay for respite if there's planning to try to get them a place to live or hooked up with services. So that RFP is out, and we're getting close to have the negotiations with the provider to bring that up at this time. Yes?
Are there any, with the hubs that you're talking about, that's coming soon, will there be any, like cultural centers involved with the hubs since, we do get a lot of refugee families, or you do get a lot of, and sometimes they prefer to talk to people that they can relate to or things like that. So in what way, I guess, a partnership with that hub and like culture centers or different things, like is that something that is taking place as well, like a conversation about that as well?
Thanks for bringing that up. I do think that is one of the things when we talk about a recovery-oriented system of care that the regions are trying to constantly do is bring in the cultural pieces. I cannot answer to say yes there will or no there won't because it's in development right now, and our portion is the behavioral health piece. So we're going to fund the behavioral health component of that. It may look different after it gets launched. And our intent is to bring up the services even before the center's even built for families. So at some point, yes, I would envision that there may be general assistance. Maybe Lancaster County might want to locate, or some of the counties might want general assistance located in there. Or there may be some type of cultural piece that the community says, you know, we're having this influx of these types of ethnicities or these types of dialect that's coming, that we need to kind of partner with some of them. And we do partner closely with the Vietnamese Center or Asian Center, I'm not exactly sure what their name is, but they serve 10 different dialects. So we're constantly working with them on plans for one, on folks that are at the regional center that speak a certain dialect that are needing to get reintegrated in the community to work with them. So I hope so. I would like to say yes. I wanted to just talk a little bit about the recovery-oriented system of care. So really what you'll feel from the regions, I believe, I'm hoping you're feeling this from the regions, is that we're not that medical model. We're not, you know, you go into the doctor, you get a prescription, you kind of move along. It's more of this kind of focusing on what are your strengths and how do we build upon those? Or how do we look at you in a holistic type of way, not just kind of pointed on your diagnosis or this presenting problem. It's going to be kind of looking at your health. Do you have a home? Do you have purpose? So some of the pieces, we have different services, for example, like certified peer specialist that is in our service array. And if you go to each one of the regions, you'll see all the different array of services that are provided. And sometimes it's really just trying to engage folks and having them somewhere to go. Virginia Selleck really talks about everyone should be afforded the opportunity to work. You know, so that's one of the services that we're providing is supported employment to help people, even if you are on disability. There's been some changes in some of the rules and regulations so that you can still be on disability and work. I mean, because we know that a lot of people get fulfillment and feel productive. So when we talk about the recovery-oriented system, it's not just those medical services or kind of Medicaid services. It's those, but it's way more. It's way more than that. Does that make sense, kind of what I'm saying? Any questions about that?
It's in addition to like more of an educational system that you're educating parents, you're educating adults on how to get these resources.
Yeah, it is, that's right. And we believe that adults and the people that we serve know how to solve their problems. We honor and try to privilege their knowledge about what to do about their problems. And then we just kind of work with them like, well, this is available, and how do we navigate this? So it's a little different approach is what you'll probably feel from the regions. All right, and this is just another slide to kind of illustrate that recovery-oriented system about promotion. So Patty talked about the prevention services that we are doing. Every county, one of the counties may be focusing on underage drinking. Another county is focusing on the suicide deaths. Another county is focusing on vaping, different campaigns. Another county is focused on social emotional learning in schools because they are recognizing in their school district or their school system that youth are presenting with lots of emotional dysregulation. So we're trying to kind of get ahead of it and teach some of these skills and with promotion, prevention, and then treatment, and then ultimately recovery. I'm going to pass this off to Thomas to talk about some of the statewide initiatives.
Sure. All right, so I want to kind of continue and cap off a little bit about that to kind of continue about the recovery-centric system of care. One of the cool things about DBH is the ability that we have to kind of create some of these services that are able to acknowledge some of the gaps in the system. So for example, right now DBH, we cover all the crisis response services where if you need to have a quick intervention with somebody, DBH is typically the one covering that. Medicaid has a medical crisis stabilization service that they do if you need to be in a hospital and medically stabilized. That's one component they offer, and then they offer a 2-hour contact with a clinician. So those are great services, but we have this ability to make a service that says, hey, we can just have some trained staff. They don't necessarily have to be licensed. They can interact with you. They can de-escalate you. They can hook you up with community resources. We have the emergency community support so that, you know, hey, in an urgent situation, we don't have to enroll you and do a full mental health assessment and all that kind of stuff. We can get you hooked up with community resources you need in an urgent manner so that you can get off and hopefully have some assistance with getting that crisis resolved. So that's kind of the cool thing with DBH is we do have this capacity to kind of build, innovate, and fill in some of these service gaps where maybe like a traditional Medicaid service may not. And we can pick up those services for Medicaid covered individuals if it's a completely different service, or if there's someone that may be just out of the threshold of Medicaid, but still might be struggling if they have like private insurance or something like that, we can kind of hit those folks in the gap, which is where we really get to holistically address our community, which is awesome. I'm going to focus on two initiatives here. We got a few minutes left. I'm going to give kind of a brief trailer for our 988 system. Michelle Nunemaker will be speaking at 1:45 in this room today to give you some more detail on it. But I want to just kind of highlight quickly, in a lot of cases, an individual's path into the behavioral health system really kind of starts with that crisis response service. And over the last couple of years, we've been working very, very hard to bring on this 988 system. Just to go over it a little bit, people know that you call 988 and this is something, you know, you talk to someone, it connects you automatically. There's also a text option and there is also a chat option on the 988 website. And that's really kind of a cool thing. We're seeing that more people are kind of liking to engage with that medium because sometimes it's really just hard to even have that over the phone conversation. It gives them a way to engage when maybe just talking on the phone is creating some anxiety for them. So we think that's a really cool area. I'm going to briefly just show the 988 call process here. But a call come in, crisis counselor answers the call. Maybe the call is managed by the crisis counselor as information and is transferred to 211 for kind of community resources if appropriate. Or the counselor can de-escalate and do some safety planning. They safety plan or they can activate a mobile crisis team. Or the third pathway is the crisis counselor transfers them to 911, CPS, or a hotline as appropriate. So really that 988 crisis line is a really nice, easy one-stop shop to either get you referred into services, get you referred into emergency services if appropriate, or even just kind of have a conversation to de-escalate if neither of those are appropriate.
And I just want to say, if you haven't called it, call it. I called it just the other day because I go out and talk to all these folks about 988, and I had not called it yet, but I'm telling people to call it, so I called it. So just call it and just say, I just want to see what it's like, what the people that are going to be calling this are going to experience. Or someday you may have that behavioral health crisis, because we know behavioral health crises don't discriminate, whether you go to Yale or jail, right? So it's
Well, and on Michelle's presentation today, I believe she has a little video that shows exactly what the experience is like. It's available on our YouTube, DHHS YouTube. You can see all that there. I'm going to show some fast statistics here. This will be kind of a chart of all the calls that we've had since July of 2022 when we were fully up and running with this. With the individuals that call, sometimes they drop off. We have a 96% response rate on this as of April of this year. And we've only had about 45 abandoned calls. That means the person maybe hangs up within 10 seconds. So over the course of this, we had a really, really high contact rate. People aren't hanging on the line a long time. We really are getting that urgent response to them immediately. And then this is the chat versus text volume. And basically what we're seeing is not as much utilization as the phone call line, but we're still seeing a couple hundred people often using the chat mechanism off the website or the texting 988, serving about 2,100 individuals over the last year. So it's still making a really good impact for those folks that where a phone call may be difficult.
Thomas, I just wanted to add that it's on average, I believe, around 55 calls a day that they're receiving. They can handle up to 200 or 250 from our last dialogue with the
Yep.
Police Town Hotline. So
Accurate.
get the information out and let's get people calling.
I skipped ahead here a little bit. But this is kind of the total call volume that we've had across all of our regions. And again, you can kind of see a little bit of that population breakdown that Patty and Patrick were discussing earlier. At 6,500 calls out of Region 6, making up about 48%, 3,200 out of Region 5, 600, 900, 400, for a total in the last year of about 13,467 calls, which is huge. That's a ton of people that have been able to help de-escalate the crisis situation. It's a really major, impactful program we're very proud of. I'm going to skip ahead here a little bit in the interest of time because this is something I really want to talk about. I'm super excited about this one. So recently, on May 25th, 2023, so not even a month ago, Nebraska passed legislation LB 276, which is our kind of initiation of bringing CCBHC programming to the state of Nebraska. Who's heard of the term CCBHCs before? Okay, we got a couple. Oh, you're going to learn today. All right. So I'm born and raised in Nebraska. I spent a good 10-year period down in Missouri. Missouri was one of the 9 kickoff states for this federal CCBHC program. So we were a pilot state. We received some funding from SAMHSA. We really got to try out this new regulatory process and really got to try as a state to bring this program online. So we have 5 CCBHCs right now currently in the state of Nebraska, but they are credentialed through the federal authority, through SAMHSA, to be a CCBHC. What this legislation does is it allows Nebraska to kind of adopt a new payment system, its own set of regulations and standards, its own data collection mechanisms, so that we can really make this meaningful for this existing CCBHCs that we have, and then as a state start bringing more online based on what the needs of Nebraska look like. So what is a CCBHC? Well, first off, who can be one? Basically, any kind of nonprofit organization, as long as it has the components that satisfy the criteria. In Missouri, what that basically looked like was basically any kind of accredited behavioral health center, community behavioral health center. So if you're CARF accredited, COA accredited, JCO accredited, you were like 90% of the way on your way to being a CCBHC. So as far as like the regulatory stuff or the standards, most people are already there. The kicker is that it really is kind of contingent on bringing a certain service array online, okay? And so what the cool thing about CCBHCs is that it really requires these level of core services. So it's requiring outpatient mental health and substance use services, crisis services, targeted case management, that care coordination piece, psychiatric rehab, integration with primary care and med management services. So it's truly trying to create a center that's a one-stop shop for all your behavioral health needs. The cool thing about this is that you can, if you are maybe a primary care provider and you want to start helping out a CCBHC, they can contract with you and you can be what's called a designating collaborating organization. And you can kind of be a part of that CCBHC network, which is awesome in rural communities because what happens is we oftentimes have a lot of primary care physicians. They're usually that first point of contact for behavioral health in rural communities. They don't typically have a place to refer people to. So what happens is they don't want to do the screenings for behavioral health because if they find a behavioral health problem, they're obligated to refer it into a system. And if they don't have anyone to refer to, they're not going to be looking for those difficulties, which is a bummer. What this does is it allows for some of those relationships to be created, and it also allows, I think, for how it worked in Missouri at least. I'm not sure how we've framed it out here or how we're still in, it just passed. So, but in Missouri, it was allowing that you could get into kind of this new payment rate if you're a physician or a designated collaborating organization. So whereas maybe a provider was saying, or a physician was saying, it's not really sustainable to maybe have a behavioral health professional on staff, this kind of gives them a little bit more incentive to maybe integrate or collaborate with a licensed professional. So that's a huge thing. The two other cool kickers about the program. In Missouri, what we did is we had what was called a prospective payment rate. And what that allowed for was kind of an expense-based reimbursement for the number of services that were in the CCBHC program. So that was to say, instead of paying you a rate for outpatient psychotherapy, community support, peer support. What we would say is if we were going to take all your expenses associated with those 3 services, and we're going to give you a daily rate, and that includes all the expenses like care coordination or things like that that aren't necessarily bundled into those fee-for-service rates. So it's really, really cool because you get that daily rate regardless of when the service was provided. So if you do 2 services on a day, you get the daily rate. If you do 1 service on a day, you get the daily rate. And it really allows for more of those ancillary costs like case coordination, case management. We saw behavioral health blow up in Missouri as a result of CCBHC implementation. So it's a really exciting program. We're hoping to bring all of these elements to Nebraska as a result of this new legislation.
And Thomas, there are some already
Yes.
in existence.
Right.
With federal grants, they've been
Correct.
able to already get some of those in existence.
Correct, yes. And the federal grant money has helped brought those up. Those are those 5 that I mentioned. They helped kind of bring the startup and the funding for it, but they're not totally subjected to, or they're not totally in that prospective payment rate because that's totally a state Medicaid thing. So that's kind of the thing that we're really starting to work on developing, and DVH is going to try and match that in the ways that we can. Here's just a few more items about CCBHCs that kind of talk about how it innovates in the field. It really does allow for more of that crisis continuum of care. It really does work on improving that health equity, and it does have some really great, so the third thing I was going to mention, data outcomes actually coming up to the state so that we can actually get a good roadmap of what's occurring in the state across access times, adherence to medications. We had some really cool things where a clinic would submit metrics to the state, and the state would join those metrics with the clinic's metrics, and we could tell to say, hey, you got prescribed an antipsychotic medication over here, and then we looked at the claims data and saw that your client filled that medication over at a Walgreens 3 days later. Boom, we can tell that it takes 3 days to get antipsychotic medications filled. So we can see where those gaps are on a number of these metrics, and these are federally made metrics. Some of you guys might even be reporting them today, but it does support that infrastructure so that we can see that kind of information and really get a better pulse on what's going on in the community. So that's an awesome component of it as well. So there is the contact information for our regional behavioral health authorities across regions 1 through 6. This one's mine right here if you have any questions for me. But do you have any questions? We got a couple minutes left. Is there any questions you have for me or Patty or Patrick? All right. Well, it was so great getting to speak with you today. Thank you guys so much for your time.